Hello, good evening. Welcome to a new webinar series by Ryonex Biomedical Limited, directly from the studio in the Sauerland Pyramids. Also, from my side, welcome to the new webinars. So, we are very happy to offer you a new series of webinars, and I promise it will be great. Yes, indeed. That means that today's webinar won't be a single standalone webinar, but it will be part of a webinar series consisting of 4 webinars on one main topic. That's how we're going to do it. And today we are not alone. As usual, we have guests to support us. We have Mrs. Schipper from the Paul Schmidt Academy, who will speak about physiology, and Mrs. Porsche from the Paul Schmidt Clinic, who will present the medical part based on her clinic's experience. Yes, and now let's come to the main topic of these webinars, Ms. Brockenburg. Yes, respiratory infections, a very big issue. Well, I think everyone will agree with me because it has really determined our lives over the last few years. But in this series, I don't want to explicitly talk about the pandemic. Instead, we are going to look at it more broadly because these kind of things have been around before and will continue to be. So respiratory infections, I think that's just an area where many people, especially when there are minor problems or only few symptoms at the beginning, like to support it with bioresonance according to Paul Schmidt. The first webinar will be a basic webinar. You will certainly remember it from last time. It's about, knowing what happens in the organism, which are the symptoms, what does the respiratory tract really mean, where is it located, what is it part of, and what is not part of it. And that's very interesting. And we are keen to learn about that. And for this purpose, we have invited some guests, as already mentioned, Mrs. Kerstin Peuschel, a senior physician of the Paul Schmidt Academy, who will give us some insight, and Mrs. Bettina Schipper. Yes, exactly. And before we get into this webinar series, we would like to point out the following. Here we are talking about the medical field, and therefore, as always in our webinars, we would like to mention this legal disclaimer. Please note that the information and advice given in this webinar are not a substitute for treatment or a visit to an alternative practitioner or naturopathic doctor. We would also like to point out that despite the clinical perspective, double-blind randomized study, and the many in vitro studies, clinical conventional medicine has neither accepted nor acknowledged the effects of bioenergetic oscillations. That is a very important disclaimer, and with that we can jump straight into the webinar. Yes, so let's start with the contents of our first webinar. Mrs. Bonkenburg, yes, we are both moderating it, as you can see and hear. You already know us, and you also know Mrs. Bettina Schipper as Director of Studies of the Paul Schmidt Academy. She will again be talking about the following topics: what happens in the organism. She will be speaking about the physiology and the processes. And as mentioned, we will also hear a presentation about the medical part as well as experiences from the clinic. For this, we have invited Mrs. Peuschel as senior physician of the Paul Schmidt Clinic. She will present the clinical details. That's the content. Yes, I'm really looking forward to it. The last webinar we had on intestinal health was also brilliant. So let's talk about the second webinar. Yes, the same goes for the second webinar. We will be moderating it again, but we will have a completely different guest. We will have Bärbel Philipp. She is a naturopath and a chemical engineer. I think that's quite a rare combination. It will be a very, very interesting webinar. Mrs. Philipp has been working in her own practice since 2007, started as naturopath, and then decided to focus on BAPS, so bioresonance according to Paul Schmidt. She combines the BAPS with enzyme therapy. So she's very knowledgeable in the field of enzymes, has chosen a combination of programs, and she will present it in this webinar. So the title of the webinar is Helping Respiratory Infections with Enzymes, Minerals, and Vitamins. Perfect. It will be broadcasted on 1st of March 2023. And now let's talk about the third webinar in this series. Yeah, the third webinar, you had already referred to it earlier. I found the topic very interesting. It is electrosmog exposure and asthma. That's why it's a wonderful addition to our series. Asthma is a disease of the upper respiratory tract. And it just fits perfectly. There is a very recent study on this topic, a US study, which we will be presenting. And I would also like to introduce Jörg Günther at this point. He is a graduate engineer and our building biology measuring technician at the Paul Schmidt Academy since 2011. And he will advise us to tell us what we can do about electromagnetic pollution, or what can we do about e-smog, and what are biofield forming devices and what can they do. I'm looking forward to the presentation of the study, and that's really new. Let's speak about the fourth webinar. Did we say the broadcast date? Yeah, we go back. So yeah, it was the 8th of March. Right, the 8th of March. And the fourth webinar, the summary. Yes, the summary. This may sound trivial at first, but I can promise you that this is a very important part. As last time, we are always very happy to answer your questions. That is just a very nice interactive part where you can simply participate and ask questions. Of course, you also get them answered in the Therapy Counseling Center. So what we do is the following. We filter most frequently asked questions, so those things that are asked more frequently, and they will be answered by us. And for example, also questions regarding inhalation, for example, and tips and tricks, or questions on how I can make a specific tea. So the fundamentals and the basis of BIPS, exactly, broadcast date, 15th of March. Yes, exactly. The aim of this fourth webinar is, of course, as you said, to get the most frequently asked questions answered. In the many webinars that we have already done, we have seen time and again that sometimes there were also very unusual questions that did not really interest the majority. And that's why we do it like that. So like last time in the webinar series, in the value webinars, because it has proven itself. So let's speak about facts and figures of the subject. Yes, it's best to start with facts and figures. As I have already said, this is a really big issue. And by that, I mean it affects very many people. So let's take a look at some figures. If you do some research, you will find out, for example, that after these two COVID winters, around 9.5 million people are currently acutely affected by cold and flu viruses. I think that's a really large number. Now, our main problem are no longer the coronaviruses, but the RSV, the respiratory syncytial virus. It mainly affects children, but also adults. There's always something new coming along, so we have to look at it holistically instead of focusing on individual pathogens. And of course, there are also many people with chronic obstructive pulmonary disease, COPD. In Germany alone, there are 6.8 million people with COPD, which I found astonishing. And an estimated 210 to 340 million people worldwide are affected by COPD. So that is almost unimaginable. Yes, and it shows that we have chosen the right topic. Yes, I agree. And but last but not least, I would also like to come back to asthma. I have already mentioned that there is a connection between electrosmog and asthma. Around 10 to 15% of children and up to 7% of adults suffer from asthma. That is around 8 million people. So asthma is also a very interesting and important topic for us. And I think we can give a lot of tips, tricks, advice, and information on that. Exactly, Mrs. Bunkenburg. And now let's get to our first expert speaker. Mrs. Bettina Schipper, a naturopath who is director of studies at our Associated School of Naturopathy. She is, of course, predestined to present the physiology of the respiratory tract. Yes, Mrs. Schipper, a very warm welcome. And of course, we're looking forward to your presentation. A very good evening, Mr. Heimes, Mrs. Bunkenburg. A very good evening from here, from Lennestadt. My name is Bettina Schipper. I am naturopath and director of studies of the School for Naturopathy of the Paul Schmidt Academy. And today I would like to give you an overview of the anatomy and physiology and also the functioning of the respiratory system. The respiratory system is anatomically divided into the upper and lower respiratory tract. It starts with the nose, the so-called paranasal sinuses. There are 4 different ones which come always in pairs and have a direct connection to the nose. And then the throat, which is also known as the pharynx. Below the upper respiratory tract, there is the lower respiratory tract, beginning with the larynx. And below the larynx is the trachea or windpipe. Below the trachea, there is the division into the main bronchi, where we have the bronchi and the bronchioles, which are the smaller structures. And from the bronchioles, we have the alveolar, the ducts, the alveoli, also the air sacs, which are responsible for the gas exchange. The gas exchange is an important process in the alveoli. So it's the absorption of oxygen and the release of carbon dioxide, which is the most important thing in the body. All body cells, tissues, and organs are naturally supplied with oxygen and nutrients. What are the functions of breathing? In the nose, the air we breathe is purified, it is humidified, and the air we breathe is also tested, especially with regards to odors, which is also an important protective mechanism. Breathing also influences the voice production. The different areas of the nose, the sinuses, are also important for voice production and resonance. What is gas exchange? Here we see the detailed explanation. We have the terms of external respiration and internal respiration. Respiration is the technical term for breathing. It is the exchange between the blood and the air. This means that when I breathe in oxygen, or more precisely the oxygen mixture, I take it into the lungs, and in the alveoli, the gas exchange or the transfer of the oxygen-rich blood into the capillaries take place. Internal respiration, which must be differentiated from external respiration, is the so-called cellular respiration. That is what happens in every cell of the body, the exchange between bloodstream and tissues. This is also very important in order to make sure that the oxygen can reach the individual cell organelles. The physiology of respiration, the functioning of respiration, I will summarize it again. So heating, humidification, and pre-purification of the air we breathe. This is considered an important filter function because in the nose there are mucous membranes which contain the ciliated epithelium, where, for example, foreign bodies that were inhaled are transported to the outside. The smell perception, which, as I said, is a very important protective mechanism, tests the air we breathe through the olfactory organ, that is through the nose, and through the olfactory nerve, which is directly connected to the nose. This is the first cranial nerve, and the nose also is an important resonating chamber for the voice. Every one of us knows that when you have a sinus infection or a cold, your voice often sounds a little different, and when the sinuses are inflamed. In sinusitis, for example, the sinuses have a direct connection to the nasal cavity or nose. They include the paranasal sinuses, the maxillary sinuses, the so-called sphenoid sinuses, and the ethmoidal sinuses. All these sinuses basically come in pairs and have connection to the nasal cavity. Their function is to widen the nasal cavity and also to reduce the weight of the bony skull, because due to the bony structure, the skull and the entire body is relatively heavy, and the nasal sinuses contribute to a weight reduction. I've already pointed out that for a clear voice formation, it is important that the nasal sinuses and the nose are free. And I've also mentioned warming of the air we breathe, which is particularly important when it is very cold outside, for example, to avoid a cough reflex being triggered. Nasal breathing is considered the healthier way of breathing, and when you need to breathe more, you would additionally breathe through your mouth, for example. And if the nose does not function properly, for example, the nose is blocked, for example, you would mainly breathe through the mouth, and when it's cold, that would usually trigger coughing. Here on the slide, you can see the anatomy and physiology of the entire respiratory system. I'll start at the top left. We have the pharynx with the nasopharynx, the oropharynx, and the laryngopharynx. The nasopharynx starts behind the nose, then comes the oropharynx, which you can also see from the oral cavity, and below that, just before the trachea, begins the so-called laryngopharynx. And the larynx has the function of voice production, and above all, it closes the windpipe, the trachea, when swallowing. There is the epiglottis that is close, set so that you don't get any food or drink into the windpipe where you would have to cough as a reflex. That is a safety seal to make sure that it all works properly. And at the larynx or below it, you find the xiphoid cartilage and also the epiglottis, which is attached to the larynx. Then below all that, you have the arytenoid cartilage, and the last section before it goes into the trachea, into the windpipe, is called the cricoid cartilage. This is somewhat larger, firmer, and represents a transition. Vocal cords and glottis contribute to a sufficient voice production. The internal muscles of the larynx move the vocal cords, and of course important because without muscles, the cords or bony structures would not move. The windpipe then joins the so-called trachea, and the trachea begins below the cricoid cartilage, which I mentioned earlier, this large solid structure underneath the larynx, and ends approximately at the fourth thoracic vertebrae. So that would be the anatomical position and the points where it divides. Medically, we would speak about a bifurcation. And there the trachea divides into the main bronchi. I will come back to it in a moment. The length of the trachea is about 10 to 12 centimeters. It runs behind the thyroid gland and in front of the esophagus. So the airway crosses in the throat area. As to the structure of the trachea, it is made of mucous membrane and connective tissue. And what is special are the 16 to 20 cartilage rings that are around this trachea in a C shape, and it makes sure that the trachea is held open far enough, especially during forced, strong breathing, and it cannot close so quickly. This is a very important structure. Below the trachea is the bronchial tree. At the level of the fourth thoracic vertebra, there is a division, and from there it goes into the right and left primary bronchus, and from the primary bronchus it becomes smaller and smaller to the so-called lobar bronchi. The lobar bronchi then leads to even smaller segmental bronchi, which are like small partial bronchi, and then the small bronchioles, and at the end the so-called alveoli, air sacs, and that's where the actual gas exchange takes place. There the oxygen-rich breathing air or the breathing air mix is brought into the capillary area via these small membranes of the alveoli, so that a gas exchange takes place between the alveoli, and the vascular area and the oxygen can get into the blood, and the oxygen-rich blood can be transported from the lungs to the left heart chamber. Because in this ejection phase or systole, the left heart chamber brings the oxygen-rich blood into the entire large main circulation. These are the anatomical and physiological conditions of the respiratory system that I wanted to introduce. And many things from this anatomical, physiological area can also be used for pathology. So, for example, what happens when the respiratory tract becomes diseased, when something is inflamed, when something is displaced, or when the respiratory tract is chronically inflamed. Yes, Mrs. Schipper, many thanks again for the explanations on anatomy and physiology, in this case on the respiratory tract. It was very interesting as always, and I think also well explained. Great. Yes, this brings us directly to the second speaker, Mrs. Bunkenburg. Yes, we are now going to the Paul Schmidt Clinic, and when I say Paul Schmidt Clinic, you know by now that Kerstin Püschel will now tell us more details from her practice, from the treatments, and also from her patients. Yes, Mrs. Püschel, welcome to our webinar. Hello. Yes. Thank you very much for the nice introductory words. Most people probably already know me. For those who don't know me yet, we are located in the center of Germany in Heilbad-Heiligenstadt on the A38 highway. We are the Paul Schmidt Clinic. I'm a surgeon and a thoracic surgeon. I've been working with bioresonance according to Paul Schmidt since 2002. And today I have the privilege of talking about respiratory infections. So, currently it's a big topic. Everyone sniffles, everyone sneezes, everyone has heard something about it and is affected in some way, either themselves or someone in their family. And I just wanted to shed light on it and explain what we can find here. I have divided it up. First, I will speak about the term infection. And then I have divided it into these large pathogen areas, viral infections, bacterial infections, fungal, and also parasites. Although the latter is rare, we need to keep it in mind. And I also brought some patient examples from practice, where you can see how far it goes. It will be about what can you actually do in general, and where are the boundaries between the individual areas and of the respiratory tract. Infections of the respiratory tract. Of course, there are different pathogens. There are viruses, bacteria, fungi, and parasites that can cause problems. In other words, there's always a pathogen and a host organism that interact with each other. And this entire interaction is determined by various factors. First of all, of course, by our great weapon, our immune system. We have the specific immune defense which we acquire after birth. It is not primarily there, but is developed through contact with pathogens. These immune defenses are formed in the first months and years of life. It is cell-related, mainly in the area of the T lymphocytes, and fluid-related, humoral, in the area of the B lymphocytes. Our non-specific immune defense is what we have inherited, what we have in our genes, and what, of course, also slightly varies from person to person. Here, too, we have rather cell-related defense. These are all the phagocytes that we have to render pathogens harmless, but there too an immune defense would take place via the so-called complement system. It has the task of simply attaching little stickers to the pathogens so that they can be recognized by the system and processed accordingly, for example, render them harmless. The pathogens are, of course, adapted to specific hosts. There are certain receptor structures that make it possible so that not every pathogen can dock onto every individual. For example, there are pathogens that only affect other mammals, such as rabbits, and other pathogens are specific to birds, for example. And there are also some that can be effective across species, which then also affects humans. The pathogenicity of the pathogen is also very important. Some pathogens are very aggressive, highly contagious, and they definitely cause an infection. From there are weaker pathogens that go from there down to zero, I would say. There are also pathogens that we need, which are indeed bacteria that live in symbiosis with us and do no harm, or so-called opportunistic pathogens, which will only cause an infection if my immune system is very weak or if these pathogens are present in a very large number, in a number that is otherwise physiologically unusual. In these cases, they can, of course, also lead to problems. What does such a pathogen do? The pathogen invades the cell, causes destruction, and then triggers an inflammatory reaction. Or the pathogen produces toxins, exotoxins, which then in turn affect our cells. Sometimes the pathogen does both. So what happens then? What happens in the body is an immune system response, a normal antibody reaction with complement activation and activation of the whole inflammatory cascade as a result. And then there can be disease or reaction patterns such as allergic forms, which also have been described. We will remember that there are 4 types of allergies. Firstly, type 1, this immediate allergy, IgE mediated type, then type 2, which mainly takes place at the cellular level, which can mainly be found in transfusion medicine or transplant medicine with IgE and IgM antibodies. Then type 3, allergy in the area of immune complex formation in the blood, for example, also via IgM, IgE mediation, or the late onset reaction, the type 4 reaction through altered or activated lymphocytes, which is very well detectable with the existing lymphocyte transformation test. Let's start with the viruses. They are our main concern during the cold season. Here we have very well-known pathogens, of course, rhinoviruses, adenoviruses, and enteroviruses. These are the ones that are mainly present in this phase of the year, but also the para-influenza viruses. Of course, there are also others, as we all know. Unfortunately, we still have SARS-CoV-2 and also the influenza viruses that are coming back every year and actually trigger the flu. The route of transmission is, as we know, droplet infections, but also smear infections. These viruses invade the host cell because they need the host cell to multiply and cause their damage. So they multiply, then destroy the host cell, and this triggers the inflammatory reaction of the body. And these infections are normally quite uniform. So what happens? There is an infection of the upper respiratory tract. So runny nose, coughs, sore throats, and of course the well-known general symptoms. So you are tired, you have fever, you have a bit of bone pain, you feel tired and worn out. Now, infection of the lower respiratory tract and, of course, the general symptoms. I have written them down again: bronchiolitis, pneumonia, but also inflammation of the larynx and croup. So sometimes it starts at the top, moves down, moves up again, or the upper and lower airways are affected in equal measure. Of course, there are also complications with viral infections, especially in the respiratory tract due to the swelling of the mucous membrane, our inflammatory reactions, immigration of inflammatory cells, and water accumulation in the mucous membranes, the airways change. This leads to stridor, which is the narrowing of the airways during inhalation exhalation. The paranasal sinuses may also be affected, and the middle ear may be affected. But it can also happen that pathogens or infections affect the heart. Here I wrote down endocarditis, which is an inflammation of the inner lining of the heart and can sometimes lead to death. If the mucous membrane is damaged in this way, it can easily invoke other pathogens, for example, bacteria and fungi, which then can also grow in the damaged mucous membrane simply because the defense mechanism of the mucous membrane are no longer working. Our barriers, our innate immune protection barrier, like the skin and the mucous membranes, are then no longer working in the same way. Of course, we have the well-known cold symptoms, but also general symptoms as mentioned earlier. The patients often have fever. You can take a swab test. As we have seen with SARS-CoV or influenza, it works very well. With others, the swab tests are not very reliable. Okay, you can try it, but you also have to make sure that you keep it within an appropriate limit. You should ask yourself, do I really need it now? Or can I also determine it with my senses? Can I determine that it's a viral infection? The secretion is usually not conclusive. Okay, people with a bacterial infection usually have more of a yellowish secretion, but it's not necessarily conclusive. Sure, if it's purulent, it's usually yellowish, but it can be everything from yellowish to whitish, even with viral infections. The clinical examination is important. You have to listen to the patient to know how far down it has gone. So the question is the lung already affected or not? If necessary, I have to order an X-ray or a lab test if I cannot exclude the possibility of pneumonia. In the lab, the usual findings would be a slight depression of blood count, especially with advanced viral infections. What can I do? Viral tests only make sense at the beginning of the infection. After that, they are basically useless. As to the symptomatic therapy, the patient needs a lot of rest. You can give symptomatic remedies against cough, expectorants. There are very, very nice medicines in the field of phytotherapy, also in the field of homeopathy that can be given to support the patient. Of course, the patient should drink a lot, can be treated very well with bioresonance. The patients can lie on the chair, wrap up nicely, get a warm team, get the complex programs, and it works very well to support the immune system in a symptom-oriented way. And of course, you can combine this with giving patients other medicine or even an infusion. It's good if they get fluids, a few vitamins, zinc, vitamin C, for example, is very helpful, or also other homeopathic complex preparations, things to loosen mucus. This can be done at the same time, and it can simply shorten these infections. When it comes to prophylaxis, hygiene and strengthening the immune system are clearly important. And here the appropriate vitamin supplements come into play. You can take complex preparations, like different complex preparations, mixed preparations such as Rayovita. And of course, you can also do prophylactic bioresonance in order to strengthen the immune system very effectively. Bacterial infections. Well, here we are dealing with somewhat more developed organisms. You can see it in what happens or what can happen. I've written down some known pathogens, pneumococci, which comes up now again in the cold season, but also streptococci, especially type A, whooping cough pathogens, Klebsiella But one must also remember that patients can have tuberculosis as well, and also the actinomycetes, so that can be very, very tedious, especially in patients with previous damage who already have preformed caverns in the lungs, who have preformed formed hollow spaces, like in the case of emphysema patients, which can then have these relatively highly developed bacteria, which sometimes cause very unpleasant protracted inflammations, either as granulomas, but also disseminated in the body. So chronic forms are very common, but there can also be acute episodes. It is very often confused with fungal infections, but also with neoplasm. It's important to remember that this also exists. When there are fistulas in the organs or things like that, then it becomes relatively complex and very complicated. Routes of transmission, obviously droplet infections, smear infections, but it can also spread very easily through the blood and vascular system. The bacterium attaches to the host cell and penetrates. It causes inflammatory reactions in the body, causes cell destruction or cell damage through exotoxins. This too can be divided into infections of the upper and infections of the lower respiratory tract. It is similar to viral infections. Here too, many complications can occur. Of course, these often also affect the paranasal sinuses, the ear, in the otitis media. Other pathogens can also take over. Some of these bacteria that can simply come along, for example, the actinomycetes or the pathogens can spread to other organs and can lead to blood poisoning and sepsis. Symptoms, again, cold symptoms in general, also fever, especially if it already successfully spread into the body. In these cases, we will have very high fever curves. What can be done? You can try taking a swab in the nasopharyngeal area to check the pathogens. It is important to check secretions microbiologically if the infection lasts for a long time, or if I really suspect specific pathogens such as tuberculosis. However, I then have to obtain it bronchoscopically, so through the bronchial system, and then arrange a culture. Clinical examination is, of course, very important. If necessary, we would carry out X-rays or laboratory tests in order to determine the inflammation parameters to assess how severe the infection is. Now, what should I do? The therapy is similar to that for viral infections. Symptomatically, I can give a very good support, also through bioresonance, if necessary, also prescribing antibiotics, and if the case of specific in the case of specific pathogens, invasive measures are sometimes necessary, from bronchoscopic measures to surgery for abscesses or fistulas, for example. Here again, prophylaxis, hygiene, strengthening of the immune system through vitamin supplements, but also especially through bioresonance, one can achieve very good results in the cold season. Fungal infections. The first thing I would like to emphasize is that if I detect fungal spores somewhere, it does not mean that I have an infection. This is often confused. Sometimes I just have fungal colonizations on mucous membranes on the skin. Fungal colonization is something which the immune system can cope with. It does not necessarily mean that there is an infection where I have to take immediate action. Sometimes I can simply strengthen the body's own immune system, strengthen and control the body's barriers, and it's done, especially if the patient doesn't show any symptoms that would indicate otherwise. What are the known pathogens? Candida, of course. You can also find it in stool samples sometimes. And with Candida, you really have to be careful. what is just contaminated and what would really have a clinical relevance? That's an important question. So you have to see how much is there, what kind of symptoms the patient has, which subtype it is, so that you don't do too much therapy and possibly harm the patient. Aspergillus is often a problem, but there are also other less known species such as pneumocystis, Histoplasmas, especially when patients work in agriculture, in stables, and come into contact with animal excrement. Then route of transmission is inhalation, but also ingestion of those pathogens. Again, hematogenic and lymphogenic. The fungus basically does the same thing. It attaches to the host cell, penetrates, and causes the inflammatory reaction. As I've already said, it develops in a relatively uniform way, especially fungal infections in patients who have a weak immune system who are going through another infection. In these cases, it is relatively common, but also in cases of anatomical peculiarities. As mentioned earlier, in cases of patients who have undergone surgery or in COPD patients who have caverns in their lungs, who have emphysema, blisters in their lungs, for example, but also patients who have had intestinal surgery where due to surgery fungi, there can be a colonization. What symptoms do we have here? The symptoms are again cold symptoms, usually not so bad or acute, but rather gradual. Chronic allergic symptoms are very common. Bleeding, of course, and also general symptoms and asthma symptoms, especially in cases of mold exposure. You always have to take those things into account. Infections of the lower respiratory tract, I had already said it. And pneumonia does that, of course, but also cavity colonization in cavities that form in the lungs due to recurrent infections, such a fungus can easily spread to other organs via the lymphatic and blood channels and can also cause blood poisoning symptoms. As already mentioned, cold symptoms, bleeding, organ symptoms, and depending on which organ is affected, but also chronic fatigue syndrome can indicate that the patient's immune system is perhaps struggling with a fungal infection, with recurrent infections. This should be looked at a little more closely. Here, it is of course important that we obtain the microbiology of the infection. It's usually a good idea to have secretions examined, clinical examination, X-ray, or laboratory if necessary. Therapy here again, symptomatic therapy, and as we have already said, strengthening immune system. Bioresonance can be very helpful there, but in the case of invasive fungal infections, we will have to administer antibiotics. Often you even have to combine them with antibiotics because bacterial infections are often added and they somehow support each other in their pathogenic effects. Unfortunately, invasive measures are sometimes necessary to finally cure the patient. Immunotherapy. There are very nice new approaches that can be used to help patients with severe fungal infections. Prophylaxis is also important here, strengthening the immune system, the same as with viral and bacterial infections. Parasite infections are quite rare, but you should definitely consider them. They also occur, and because they are so rare, they are relatively difficult to diagnose. I've only written down a small selection. Many are transmitted by animals, such as Echinococcus, the dog tapeworm, or Toxocara, the dog roundworm. We have other roundworms here. We have pathogens that occur in tropical countries, such as Bilharzia or Leishmania, for example. We have infections like Babesia, which often occur together with Borrelia and are related to the tick. And you really need to consider them and ask yourself whether it could be something like that. route of transmission, ingesting the pathogens or the eggs of the pathogen, like larvae, either by inhaling them or swallowing them, and of course also spreading them via the hematogenic and lymphogenic route. Symptoms are often similar to cancer symptoms, a tumor, especially if you have imaging, or a similar also to TB or aspergilloma. The important thing is to remember to ask the patient whether he had any animal contact, has he been abroad, how long ago was that, and things like that. The infections are often not acute, although they can be, but most of them are chronic and form cystic or solid tumors in organs. They form fistulas in other organs or cause extensive inflammation in the organ. This is very often the case with the lungs. In the case of the lungs, the infections would often not be limited to the lungs, but would also destroy parts of the bronchial system or spread further into the area. Complications. Yes, of course, as you can imagine, when the body is fighting with such a pathogen, it is not so easy. The patients are exhausted, the immune system is very weakened, there is formation of pus and suppuration, tissue is affected, necrosis, cysts and fistulas form, of course. Sepsis can also occur, especially if there is a massive spread of pathogens. If, for example, a cyst bursts and the pathogens flood into the body in large numbers, this can lead to a very serious acute reaction, including acute allergic reactions, which can even lead to death. Symptoms, as I said, are diverse depending on whether I have a generalized infection, general organ infection, or individual focal infections, or cysts in the organ. So how big are they? In this respect, the range of symptoms is very wide. Of course, it is also important to find out what kind of pathogen it is so that I can treat it specifically if necessary. I have to examine it well. I have to examine secretions, stool, urine, X-ray, lab, everything that is available to me. Symptomatic therapy, of course, always as a complementary therapy because it is good in any case, but often you also need specific parasiticides, or I have to resort to invasive or surgical measures. And of course, we also have the hygiene measures, and watch out if you travel to foreign countries that you at least gather the necessary information. So what can I expect and how can I possibly protect myself? And of course, as with everything else, strengthen your immune system. I have brought a few examples from my practice. We have an elderly patient. He has had chronic obstructive pulmonary disease for a long time and came to us with an infection. He had like putrid sputum and subfebrile temperatures, which means that his system was no longer running at full speed. His temperature was always around 38 degrees. He was very short of breath, even when sitting and speaking. We heard coarse rattling noises in his lungs. Of course, he has an obstruction, a narrowing of the airways with trapped air. You have to imagine that the bronchial structure is already very damaged in the lower parts of the lungs, so that when the patient breathes in, it contracts and doesn't get enough air in. And when he breathes out, in principle, it can't expand either. This means that old air always remains in the lungs, which then leads to the development of such emphysema bubbles, which, if they are large enough, naturally also reduce the lung volume that can still be used for breathing. Furthermore, this recurrent inflammation in COPD patients also leads to the destruction of lung tissue, scars form, pleural thickening, the lung can no longer expand properly. The whole chest, the lungs are basically trapped, partly also in pleural thickenings, so that in principle there is a chronic lack of ventilation. These small alveolar membranes widen because of the inflammatory reaction, because of the migration of inflammatory cells, which means that the gas exchange in the alveoli doesn't work properly. The membrane is simply too thick. The heart, the right part of the heart, needs an incredible amount of strength to maintain the pulmonary circulation. This leads to the cor pulmonale. Of course, it's not evenly distributed over the entire lung, but there are like hotspots with distribution disorders. Overall, the compliance of the lungs decreases, which means that it can no longer follow the breathing movements properly due to all these thickenings. Then an infection comes along. We have the additional general and the initial situation of the lungs worsens in the patients. There is more mucus, the inflammation increases, so we have more edema in the bronchioles and the alveoli, which means that everything becomes even tighter. Then we scanned the patient, of course, because he was in a very bad condition. We saw it clearly in terms of vitalization and in terms of the physiology of the heart. As mentioned, we had the cor pulmonale and pathologically also the heart waves were affected, but also the endocardium, the heart muscle was also affected. There was a cardiac insufficiency and of course the local lung-related symptoms such as bronchitis, pneumonia, also pleuritis. The patient is obviously under stress. That was also clearly visible in the scan. The patient has an increase in red blood cells simply because the body is trying to get oxygen into the body in some way, but it needs more transporters, more red blood cells. What is affected? The chest, and the respiratory muscles, the chest muscles, and of course the small and large intestine. The patient has developed a pronounced dysbiosis of the intestine due to the many antibiotics he has taken in his life. The mucous membranes are affected and the detoxification capacity is strongly reduced. Bacteria are present, so a very mixed flora, as we can see here, where one cannot say what pathogen it exactly is that comes to bear. This is always a mixed infection, especially in COPD patients. But we actually found in the patient's sputum Haemophilus influenza because he was very ill. We did the sputum tests, so we had now a precise point of attack for our further antibacterial therapy. In the lab findings, there was, of course, an increase in the inflammatory parameters, especially the procalcitonin value was greatly increased. The blood count is, as I said, not necessarily the most informative to determine the degree of activity of the infection in this protracted recurrent infections. Here, the procalcitonin value is more appropriate. The oxygen percentage was decreased as expected. In this case, we prescribed antibiosis. At the same time, the patient received an intestinal flora build-up. He received a respiratory therapy, which he received while he was getting bioresonance. That was a very nice story. It could easily be done. He also received inhalations with the appropriate medication, also CPAP therapy. This is done with a device at the end of the exhalation. Positive airway pressure is applied to the patient through the device so that the small bronchial tubes are simply widened and kept open so that this air trapping is reduced. With those patients, you can also do this very smartly by using the patient's breathing mask or by letting him breathe into one mask if he doesn't have one with him and putting it into a protective cup. where you can collect all the pathogens that the patient is breathing out, and you can simply put this into the harmonization via bioresonance without having to click on the individual pathogens, because of course some of the pathogens will also have subgroups, and with such a mask and protective cup, this can be solved very quickly and very elegantly for the patient. Our second practical example is a young patient. She is about 40 years old. She simply had a flu-like infection and came to us with a cough. We are on the second floor, so those who don't want to use the lift need to walk up the stairs. Those stairs had already taken their toll on her. She said she had fever attacks again and again, especially in the evening, and reported severe mucus. She had increased breathing noises on both sides when exhaling, so you could see that the airways were narrowed by the mucus, but also by this inflammatory edema in the bronchial wall, in the alveoli. The scan also confirmed it. Bronchi and lungs, of course, showed the bronchitis, the mucus, and of course the action of the immune system was visible. The mucous membranes, those cells always break down during such an infection. Here too, we could see the interplay between the bronchial mucosa and the intestine. That was clearly visible. It's always the case when one is affected, the other also suffers. In this case, it could be seen in the dysbiosis and the small intestine. The patient also had stress. Viruses were present, especially double-strand DNA viruses, single-strand RNA viruses, and the group 2 viruses. As expected, in the blood count, a depression of the leukocytes, the leukopenia, the blood sedimentation reaction was still normal, CRP slightly elevated. The oxygen saturation was still satisfactory at 96%. Here we did a bioresonance therapy on the patient. She made inhalation. She was given homeopathic complex preparations, at first also via infusions, because she lacked fluids, had no real appetite, a few vitamins as well. You can use the mask and the protective cup, but this was mainly a viral infection. The viruses don't normally stay in the mask. You can try that, but it might not be as 100% effective as with bacterial infections. On the other hand, you can of course do it in parallel. After all, it doesn't require any additional time or work. So in this respect, one can certainly include it in bioresonance. Our third example is a very seriously ill patient. She is 65 years old and suffers from venous granulomatosis. This is an inflammation of the endothelium, the lining of the inner layer of the blood vessels. This can lead to circulatory disorders, tissue destruction, and damage to various organs, depending on where the granulomatosis mainly occurs. Small nodular inflammations then form, which eventually lead to organ destruction. This patient had severe lung involvement on both sides. This organ destruction had already led to the formation of cavities, the so-called caverns, in which pathogens had settled. Especially Aspergillus pathogens could be found there, but also actinomycetes. The patient has had an emphysematous pocket or various pockets due to the recurring inflammations, and the obstructions also led to the development of emphysema belly there. The patient was very cachectic due to these recurrent inflammations. Her general system was weakened. Of course, she suffered from blood exudation, partly when these caverns affected blood vessels. To make matters worse, the patient really did have multiple drug intolerances to all quotation marks conventional medicines that could be given against the infections she had, but also against others like immunotherapeutics or immunosuppressants that normally have to be used in Wegener's granulomatosis. She could no longer tolerate any of these. The patient suffering had gone for a relatively long time now. She had this new additional infection. This means that the obstruction caused by mucus and the bronchial wall edema, the destruction of the bronchial walls had, of course, significantly worsened. In addition, of course, the constriction of the respiratory surface as a whole, the restraint of the lungs, the distribution disorder, the strain on the heart, and the permanent oxygen deficiency in the body caused the patient a great deal of distress. To be honest, there was almost nothing in the scan that was not altered. I've only written down a small selection such as anemia, the heart in general, vitalization, the entire energy balance of the body, the lungs and bronchi, the immune system, mucous membranes, the gut dysbiosis, of course. In the diagnostics, the blood count showed increased inflammation parameters. The rheumatoid values were increased, the liver values were increased, the chest CT scan clearly showed the extent of the destruction of the lungs. What did we do? Here you have to start therapy very carefully. The patient received a bioresonance therapy scanning for values, so that was constantly redefined depending on what was the most important at every moment. As I said, you have to work with the patient. Here again, we applied the mask in a protective cup. The patient actually also received immunosuppressants from us, at least at the beginning of the treatment, in order to somehow achieve relief or to reach a level where we can then bring about an improvement in some form. Oxygen therapy was also important for her. She received infusion therapy with vitamins and things like that, protein substitution therapy, inhalation, of course, and also homeopathic complex preparations. And later, when the patient's condition improved, we combined this with moderate hypothermia with infusion to simply improve the system a bit. Here, the aim was, so to speak, to do a cut to stop the course of infection in some way and then build up from there. And, from there you can work for the patient in a very gentle way. Okay, so that were my example from the practice, from very easy to very difficult cases. Should you have questions, I'm happy to answer them. You can email them to my email address below. Thank you for your attention. I'm looking forward to seeing you next time. Mrs. Peuschel, thank you very much for your presentation of your practical experiences. Yeah, so that's about it. But of course, we also want to direct your attention to the bioresonance devices so that you can get a feeling for what you actually might need in order to then implement it. So let's talk about the optimal equipment. Yes, welcome to the optimal equipment. We just want to show again the devices, the software, what is suitable to give optimal support. And quite honestly, there are so many possibilities now. When we present that, we don't want to say that if you have different equipment, that it's not enough or that it doesn't work. We offer a lot of possibilities. Please, especially when it comes to the Rayocom PS10, remember the test activation. I really want to recommend it again. You can try out using another module free of charge, and by this, simply try it out yourself. And once the test phase is over, you decide. That's just very, very nice. I think it's awesome. Yeah. So what do we offer with Rayocom PS10? Yes, with Rayocom PS10, we have, of course, the absolute speciality of Rayonex Biomedical Limited as a manufacturer of medical products. The basis is the medical product of Class 2A, the Rayocom PS10 Med, which already comes with the RAH medical product of class or expert system. And with that, you have the absolutely perfect equipment for therapists. I think it's an absolute must because we want to do medicine and we can also or only establish in the medical world if we have medical products. And therefore, we highly recommend the medical device of Rayocom PS10, Rayocom PS10 Med. Yes, whoever has the MET can, of course, say that he or she is a therapist and wants to support their patients. In the course of the webinars, we will also get an idea of how long you have to support in respiratory infections. There are respiratory infections that are short and severe. You only support them for maybe 2 weeks, for example. After that, the acute phase has subsided, but there are also very long chronic processes. We will get back to this in coming webinars, but there it makes sense to be able to treat over a longer period of time. And in this case, the Rayocom PS10 basic version is clearly the one that covers this really well. This means that a Rayocom PS10 basic with a therapy card really just does what is on the therapy card. It also makes the home therapy possible. The patient can stay at home, can even do it at night, and maybe go back to the therapist to have the card updated. But the PS10 Basic just offers such a great flexibility. And for many, this might not work. Otherwise, they may be immobile. Maybe their health is so bad that they can't even come into the practice. And for them, it's such a great opportunity. Yes, and especially respiratory infections often affect the whole family. So normally one person starts, and then in the course of the week and weeks, all the others follow. In these cases, the basic with the corresponding green cards is really worth its weight in gold, for sure. Yes, definitely. And everything happens under the supervision, under the guidance of the therapist. That means that with the basic, the patient is not able to program his own therapy programs. He just does exactly what the therapist recommends. This has become very established worldwide in all 45 countries where we are now established. We are very happy that we can offer home therapy in such a way, in such a combination. If you think about it, over 10 million treatments a year. Awesome. I think it's really great. Here we also see the expert system M10 and M9 so that you can get a feeling for it. M9 contains all available RAH programs, but is predestined for the therapy, which contains this module in the human field. And the module M10 also includes all the RAH programs, but also supports especially the energetic analysis, while the module M8, which is the new module, that goes in hand with the new Rayocom PS10 Lite and contains the most important compact programs so that even as a private user, you can have a very good start to the world of bioresonance according to Paul Schmidt. Yes, at this point, I would like to emphasize once again that the M8 has been newly developed and is no longer what it was before. Compact programs for the human field have been integrated, but also, and this is very new, for the veterinary field. And that's very interesting. And I always say that this is our first aid box now, if you like, because coughs and colds are things that can also be harmless. It doesn't always have to turn into something really nasty or dangerous. And it's great that with this compact program, you can react quickly. And now we are going to talk about the combination with the Polar. This is, of course, the absolute flagship of Ryonex Biomedical Limited, the Ryocom PS 1000 Polar for 0.0 MET. The medical device also contains the corresponding expert systems, test protocols, possibilities for an ECG-based biofeedback measurement to determine the necessary RAH programs. And that also gives us, again, the possibility to care for patients in home therapy. In these cases, the Polar 4.0 provides the corresponding RAH program stored on a green card, which can be used in the Ryocom PS10 Basic in home therapy. Yes, that's the same thing, but on a slightly different level, which is perhaps a bit more convenient even. What I find very nice is that in the analytics, you can use the visualization to explain something or review something, but in principle, the small and big device offer almost the same possibilities. And please remember that you can test everything absolutely free of charge for 4 weeks. That is very important for us because we want to make sure that the users who decide to use it are really happy with it, and that they can thoroughly test it beforehand. But now let's come back to the possibilities of the programs. How would this look like in relation to our main topic? Yeah, I just want to give a brief overview. This will all be referred to in detail later in coming webinars, also in relation with program recommendations. But let's just say we have our physiology that ranges from 42 to 42.82. Then we have pathology, which also fits in where you can see what is it. So 43.10 to 43.52. We have the 70s programs. I would just like to mention the three we see here: the upper respiratory tract, the lung system, or also for flu-like infections. And we also have the ATPs, for example, ATP production in the lungs. And we also have the detoxification program, which goes into in this direction. You can also detoxify through the lungs, and you can also provide some energetic support. So what else? Test protocols, so which are always a big topic. You just have a red thread or a guide for the corresponding symptoms or illness. So you have a list of the most important programs for that, and that makes testing and analysis a little easier. There are many options from bronchitis to pneumonia. And as I said, I also find the compact programs for the respiratory tract very nice. We had just mentioned the number 8. We have it for cough, for rhinitis, for example. So there are much easier ways of providing quick support. And I'm a huge fan of test protocols, as you know, and they have just been updated and expanded again. So the test protocols are absolutely up to date and can be used in the expert system of the RAH. And that brings us to the end of this quite long first webinar in the series. Well, I hope you enjoyed it, and I hope you enjoyed it as much as we did, and that you have been able to take away some new information that you can use for the benefit of your patients. So, yeah. Thank you very much for your interest, and stay healthy. Yes, and of course, we would love to welcome you back at the next webinar. So all the best and have a good evening. Bye.